Obesity guidelines. Clinicians should be aware that women with class 2 obesity and greater have an increased risk of preeclampsia compared with those with a normal BMI. Women with more than one moderate risk factor, means BMI of greater than 35 kg per meter square or greater, or first pregnancy, or if the maternal age is greater than 40 years, or if there is family history of preeclampsia and multiple pregnancy, may benefit from taking 150 mg aspirin daily from 12 weeks of gestation until birth of the baby. Remember this one moderate risk factor. All pregnant women with a working BMI of 30 kg per meter square or greater should be screened for gestational diabetes according to NICE or Scottish guidelines. All women should be offered antenatal screening for chromosomal anomalies. Women should be counseled, however, that some form of screening for chromosomal anomalies are slightly less effective with a raised BMI. Consider the use of transvaginal ultrasound in women in whom it is difficult to obtain NT, that is knuckle translucency measurements, trans-abdominally. Elective induction of labor at term in obese women may reduce the chances of cesarean birth without increasing the chance of adverse outcome. The option of induction should be discussed with each woman on individual basis. What post-operative wound care is recommended following cesarean section in women with obesity? Women with class 1 obesity or greater having a cesarean section are at increased risk of wound infection, and they should be given prophylactic antibiotic at the time of surgery. Women undergoing cesarean who have more than 2 cm subcutaneous fat should have suturing of the subcutaneous tissue space in order to reduce the risk of wound infection and wound separation. There is lack of good quality evidence to recommend the routine use of negative pressure dressing therapy, barrier retractors, and insertion of subcutaneous drain to reduce the risk of wound infection in obese women requiring cesarean section. Postnatal care and follow-up after pregnancy. How can the initiation and maintenance of breastfeeding in women with maternal obesity be optimized? Obesity is associated with low breastfeeding initiation and maintenance rate. Women with working BMI of greater than 30 kg per meter square or greater should receive appropriate specialist advice and support antenatally and postnatally regarding the benefits, initiation, and maintenance of breastfeeding. Aspirin, moderate risk factor for the development of preeclampsia, include a BMI of greater than 35 or greater. If she is preemie, if the age of the patient is 40 or more, if there is family history of PE, this preeclampsia, and there is multiple pregnancy. It is considered option of the NICE that women with more than one moderate risk factor may benefit from taking 75 mg aspirin daily from 12 weeks onward until birth of the baby. More recent evidence from a multi-center randomized controlled trial suggests that a woman at high risk of preeclampsia may benefit from taking 150 mg aspirin daily from 12 weeks. What are the clinical risks of previous bariatric surgery to maternal and fetal health during pregnancy? A minimum waiting period of 12 months, that is 1 year, to 18 months, that is 1.5 years after bariatric surgery is recommended before attempting pregnancy to allow stabilization of the body weight. Thank you.